Take note of the two distinct tendon slips of the APL and the EPB. They'll be a lot more noticeable with an L19. Now I'm going to roll the probe over here to the ECRs. As we talked about in the PowerPoint, we have the ECRB, the ECRL and the ECRB. And remember those bony prominences that tell us where that those little retinaculum, the individual compartment retinaculums begin and end, right here. So we see a little bony prominence on the radius here, and it's pretty smooth in the compartment. And then the more dorsal we go, we see another bony prominence here, which is the insertion of this retinaculum, this dark shadow. And that's compartment number 2. And then here we are at compartment number 3. We see this oval. It's kind of standalone. It's always underneath one of these little superficial veins, probably a branch of the cephalic. And to just check our work, I'm going to have our model just twitch her thumb. And that's going to activate this third compartment. So let's do a flexion, extension of the thumb. There we go. And we can see this tendon rolling. So that's the EPL in compartment 3. And then here we are on the dorsal, the extensor tendons and proprius, indices proprius here. So wiggle the fingers. And this is what I mean by like a gross anatomy survey. We're just looking for large joint effusions protruding into the dorsal wrist. We're looking for tenosynovitis and where it might originate, but not necessarily the little details of its cause. Here I can see the radius and the ulna. And above this joint, we see this little anisotropic kind of hammock of shape of another retinaculum here. And here's the 5th compartment. And I'm going to have our model just wiggle the pinky in this case. And it's going to elevate the digiti minimi. And then we're going to roll over the ulna, not quite to the ulnar styloid, but one scanning tip, especially when we get to the smaller probe, is I'm just basically going to lay the probe down on the side of the table and fire into the ulna, and you're gonna lay the probe right there on the ECU. So the extensor carpial nares is right here. So as a general anatomy survey, the larger linear array is okay. It's not great. The L15 does an awesome job for the size of footprint it is to evaluate these structures. But what I'm going to do now is switch over to the L19, and that will be much like switching over to a macro lens on a camera. All right, so I'm going to start again on Lister's tubercle. I can palpate here, and I can see a much more large bony prominence there. I'm going to bring our depth more shallow. And I like that about this, this exam type on the musculoskeletal exam type, is that it doesn't start you off zoomed in, so you don't really lose all the perspective. It starts you off pretty zoomed out like this. So you can kind of get a grasp, because we're really about to zoom in. So relative to Lister's tubercle, I'm going to go more shallow. And you can see that we're at 1 centimeter of depth. I'll click down to 1.4, and I'm going to work my way back over to compartment 1. So here is compartment 2, just radial to Lister's tubercle. Compartment 3, sitting on its own, ulnar to Lister's tubercle. Lister's tubercle being our lighthouse, how we find where we are. What I'm going to do is just roll the probe, staying 90 degrees to the radius. I don't want to lose my angle. I can't just translate the probe over. I won't get a good shot of these compartments. You have to stay 90 degrees to the cortex. And I'm going to keep rolling. So this is compartment 2. Here's compartment 1. There we go. So we can see a lot more in the image than we did before. We can still see the prominence of where those little retinaculum begin. So here's that retinaculum over compartment 1. So this is the APL, and here's the EPB. And you notice there are 2 separate and distinct tendons going 2 separate and distinct directions. So if I tilt the probe ever so slightly, you'll notice the EPB changes its anisotropic property a little sooner than the APL. Just a little tilt there. So the EPB really shows itself pretty quickly. Now, APL is normal in this case, but in some cases can comprise of multiple tendinous slips, and we don't want to call those pathology. In some people, this tendon can already show itself as a group of tendon splitting slips. As I go distal, you actually see those, but at the level of the retinaculum in some of the patient population, you can already see the vertical slips. But as I go distally, we're seeing those slips already show themselves. So here's one, here's one, here's one, there. So we had this bundle already showing itself of about 1, 2, 3, 4 individual tendon slips, maybe a fifth one right here. So in some of the patient population, right at the compartment level, you can already see those group up, and you just don't want to call it tendinosis. You don't want to call it longitudinal split tearing or anything like that. And then we'll go long axis. So the thumb orientation marker side of the probe will go proximal this time. And what I'm going to do is just go elongate these tendon fibers. And it's pretty important to denote where the extensor retinaculum is for each compartment so that you know where to look for swelling. So within the compartments, we'll go back to short axis, where we see retinaculum, you won't see a lot of effusion in these areas. You usually see the effusion proximal to the retinaculum or distal to the retinaculum, but there's not a lot of room within the shadow of the retinaculum that you see here. And the shadows are caused by anisotropy. They're little ligaments holding the tendon down. So these are little pulleys, almost like in the flexor tendon of the hand, holding these tendons down, and there's not a lot of room for fluid to collect. So that's why it's important to trace proximally or distally to look for fluid collections, but not within the retinaculum area themselves. So what I'm going to do now is when I go long axis, I'm gonna focus on proximal to the retinaculum or distal to the retinaculum, looking for those fluid collections. I'm on compartment 1, so when I go distal to the retinaculum, I'm looking for de Quervain's tenosynovitis. I'm looking for the APL and the EPB to really blow up that synovial either thickening or effusion. You can see synovial wall thickening like a big sponge around these, and that is the classic de Quervain's tenosynovitis. Now let's go back to the radius where we see those little tubercles and those little retinaculums there. Now let's go proximal, and as we go proximal, I'm going to follow my APL. Okay, let's follow APL first, and let's see what happens to it relative to the underlying second compartment. So here's APL again. Follow this oval, and here comes ECRB and ECRL underneath. So right there, that grinding area where you see those two areas literally intersect over each other. Okay, so here's compartment 2 underneath, and here's compartment 1, mostly APL, and they can grind on each other, and that is the intersection syndrome of the wrist. So proximal to those retinaculum, I'm looking for intersection syndrome. Distal to those retinaculum, I'm looking for a few things really. I'm looking for either de Quervain's tenosynovitis, which is very painful, or any pathology in the area of this little superficial radial nerve. So we have a radial nerve here. Going to add some gel because the little cephalic veins in these areas help us identify where these nerves begin and end. But what I can see here is this is one of the superficial branches of the radial nerve. As you go more proximally, it will meet up with a cephalic vein here. So here's our cephalic vein. Here's our superficial radial nerve. You remember from the elbow when we evaluated this, it keeps going and there's lots of branches to follow, and this is the more radial branch of the radial nerve, and it's called the superficial radial nerve, and it will bifurcate and then trifurcate to multiple sensory and motor branches. But right now we're just going to kind of focus on, hey, do we see any neuromas, schwannomas, compression neuropathies, tenosynovitis that might be compressing on these little nerves, and we're going to watch them bifurcate, still following this guy here, and there's another branch on the other side of the cephalic. But as we go distally, almost every centimeter or so, we see these superficial radial nerve branches bifurcate again. So here's another bifurcation. And you can roll it over that first compartment just by tilting the transducer. So what I'm going to do is just do a roll of the probe over that compartment, and you'll see this radial nerve almost make itself click over the first compartment right there. So all I'm doing is just rolling over compartment 1 proximally to distally. When you're more proximal, it borders cephalic. As you go distally, it wants to jump over compartment number 1. So go proximal to compartment 1, look at the cephalic vein. Here's the superficial radial nerve, and it's already bifurcated at this point. Here's one bifurcation here. So this is just a little off topic, but relevant for pain and burning in the area. You can see all the little fascicles here. As we go distally, you'll see it bifurcates right there. And there it bifurcates again, but it rolled over compartment 1. So that's really important because it can also get smashed superficially here. Or if you've had a patient get blood gases lately, this is usually the nerve for an ABG that gets stuck and causes a lot of residual pain later. So we'll leave compartment 1 and we're going to work our way to compartment 2. Compartment 2 is more symmetrical, where the ECR the ECRL and the ECRB are right next to each other. And they're about the same size, whereas in compartment 1, APL and EPB are not symmetrical at all. Where APL is much larger because it's got those multiple tendon slips. And EPB is much smaller, more of a dedicated tendon. Brevises tend to be shorter. Longuses tend to be longer, as we talked about in the PowerPoint. So remember how to remember it from the PowerPoint. We have longus, brevis, longus, brevis, over Lister's tubercle, longus again. So here we are at EPL, and then this is ECRL and ECRB. More important proximally for intersection syndrome, there you can see the two grinding on each other. No pathology today, it's just how it goes. Something to keep an eye out on. Right there I'm just panning proximal to distal to show the relationship and how close they come. I'm going to go distally. A little less important now, except we do have another intersection style syndrome separate from de Quervain's tenosynovitis, where compartment number 3, let's go ulnar to Lister's tubercle. We have the extensor pollicis longus here. Let's follow it and watch it jump over compartment number 2. So when I go distally, I'm going to rotate the probe towards the thumb. So I'm going to go after Lister's tubercle, following where the arrow is. Now, it's at this point I leave Lister's tubercle. You already see EPL try to jump this way. I can't keep my transducer orientation at this point. What I have to do is turn the probe 90 degrees to the thumb. I need to go in line this way because that's the direction this tendon's going to go. When I'm scanning an EPL, sometimes it's just neat to have the patient wiggle their thumb first. So what we're going to do is just wiggle the thumb. And there, with 19 megahertz, we're probably seeing 2 heads of this tendon. I've never studied whether or not there's 2 heads or if that matters, but there's definitely a slip here and 2 branches of this tendon. So what I'm going to do now is, as I leave Lister's tubercle, I'm going to go distally, and I can already see that tendon try to jump over compartment number 2. I'm going to turn the probe and aim it down the thumb, and I get a nice oval superficially here. And just like the median nerve on the volar wrist, when we're scanning a small structure that's an oval, what we're going to do is center it in the screen right here, and we're going to take small segments at a time here. So what I'm going to do is just trace this tendon proximally distally. When I feel comfortable with its trajectory, I'm going to go a little more distal. I'm going to readjust my angle, and I'm going to follow this oval again, proximally distally. And you're just going to keep evaluating that tendon until you've left the area of concern. Again, I think at 19 megahertz, I'm still seeing two individual ovals, one here and one here. I haven't studied whether or not there's two heads to this tendon, but it definitely seems like there is. So we'll have to take a look at that. Maybe ask some of you physician experts that have joined the webinar if that's some sort of variant, or if it does split into two normally. But on normal frequencies, larger footprint transducers, we don't notice those subtleties. So I just thought it was neat to kind of point that out. I definitely see one and two heads here with a little septum between the two. I'm going to go right back up to the Lister's tubercle there. I'm going to go long axis now. So I'm going to switch this to long axis. I'm going to bring the left side of the screen proximal. And if you get lost in this, find Lister's tubercle again. You always have the option of going long axis every time, but as we leave Lister's tubercle here, I'm going to point the probe to the thumb, and I'm just going to have the patient slowly wiggle the thumb back, forth, flexion, extension, and I'm going to follow the flexion extension of the EPL. Still following flexion extension of the EPL. All the way. There. It's a very skinny tendon. It can be hard to follow, but at 19 megahertz with a small footprint linear, it is much easier to follow than with a larger linear, and you can really trace these tendons down to whatever might be the culprit. All right, so let's leave, flip the probe orientation. Let's leave compartment number 3 and its individual retinaculum. Let's go to compartment number 4, where we see the extensor digitorum and the indices proprius. And then not mentioned in the slides is a neurovascular structure at this point. We scan the radial nerve at the elbow, and distally, far distally, another branch of the radial. We have the posterior interosseous nerve, more distal termination that innervates the dorsal recess of the wrist and is responsible for motor dropping of the wrist. If there's compression neuropathy here, we'll have a wrist drop of the posterior interosseous nerve. So here's compartment number 4, beautifully shown here, especially at 19 megahertz. Let's wiggle the fingers. The patients, when you're scanning this, patients really love this view because they can see their fingers wiggling, they can see the tendons activate. But what's even really cool here is you can see these tendons grinding on the neurovascular structures of the posterior interosseous nerve distally. So let's go ahead and relax. I'm going to throw on color powered Doppler, and let's just see if we can get the little artery that accompanies the nerve to show up. And there it is. So we have the artery, arrow, artery first, nerve second, right here. And if you're scanning small nerves that are accompanied by arteries, like this one, what you have to do is tilt the probe and make a really ugly tendon, okay? All the tendons look bad, but you have to aim down a vessel to make the vessel show up really nice. So you can't remain perpendicular to these small vessels when you know they're a landmark. You can't stay 90 degrees to the vessel. You have to aim down the vessel. So I'm going to tilt the probe down the vessel and make the flow. In this case, see the blue on the upper left? I'm going to make the flow go away from the probe a little bit more superficially here. There we go. And there we see that artery of that radial nerves, posterior interosseous branch at the 4th compartment, which is responsible for a lot of wrist drop if there's entrapment neuropathy. So that is the fourth compartment in short axis. Again, we do most of our scanning in short axis, but it's okay to go ahead and flip over to long axis if we expect any pathology here, and we can see the fibers beautifully. We can see the extensor retinaculum like a big airplane wing superficially. We can straighten and flex those tendons superficially and watch those tendons move and evaluate for any tendinopathy that way. But short axis is really where it's at in detail when it comes to ultrasound. If you can't see these little dots and individual fascicles of tendons, you're dealing with something that's over-processed, and you'll never pick up the subtle tendinopathies that you're looking for. So that's compartment 4. I'm going to slide over to compartment 5, and we locate compartment 5 between the ulna and the radius. Between the ulna and the radius, we have another retinaculum here, this bridge, this bony bridge between the two bones. And then above compartment 5, we have another retinaculum. So this one just really hangs out like a hammock, like we talked about in the slides. And this right here is the extensor digiti minimi, which conveniently controls the pinky. If you're an Austin Powers fan, you'll get the reference. Let's wiggle the pinky. And we can isolate that tendon in both short axis, and I'm going to go long axis here and make sure that we are indeed isolating the compartment 5 tendon to the pinky, 5th digit. Go ahead and relax. And I'm gonna go back to short axis here. I scan with 2 hands all the time. Don't be afraid to scan with 2 hands. It really helps you maintain control of the transducer. And we're gonna go back up to the ulna. We're gonna wrap the probe around like we did with the larger linear L15. And I'm gonna take a little shortcut here. I'm gonna aim into the ulna where I'm laying the probe almost to the table. And here we are in the ECU groove. So this groove contains the extensor carpi ulnaris, and it's pinned down by its own retinaculum, and we want to look for those bony prominences. There'll be one on each side. This one is less prominent, so it's more dependent on the retinaculum than the groove. But here's ECU. If I want to confirm that, I'm going to tilt the probe down and make the tendon turn dark. Her tendon is very normal and healthy, and sometimes it will just blend in with the surrounding connective tissue depending on the frequency of your transducer. And using anisotropic artifact to your favor really helps you isolate, hey, where does the tendon begin and where does the tendon end? So here I am on the ECU, and if it were blending in more, maybe with a lower frequency probe, I would tilt the probe this way and it would isolate just the ECU. And in a healthy tendon, just like all tendons, healthy tendons will turn anisotropic, and diseased tendons will have partial parts of the tendon that remain echogenic. So I'm going to go long axis by just spinning on that tendon. I'm now mid-coronal, and I see the ECU in long axis, distal ulna. Here we see the TFCC, which is not talked about in this talk. It will have to be saved for another talk over fibrocartilages, because there's a lot going on with the TFCC. But we leave the ulnar styloid following the extensor carpi ulnaris and long axis. From the extensor compartment survey, that concludes the extensor compartments. Let's go back to Lister's tubercle, and we'll quickly evaluate the scapholunate joint there. So here's Lister's tubercle, nice bony prominence here. And now what I'm going to do is just slide distally and slightly mid-sagittal. So distal, we'll see the radius disappear. I'm going to go a little more mid-sagittal, and then I see a little joint show itself very deep in the picture. I'm going to drop my depth just a little bit, and here what I'm looking at is A joint radially is going to be scaphoid. Nope, other way. So this is all scaphoid. Here's the joint space. And then here's lunate. Okay. So when we're just evaluating these, normally we're looking for ganglion cysts, ligament disruptions, joint effusion superficially, inflammation, synovitis. But for mechanical disruptions, it's helpful to do dynamics like squeezing the fist and then reevaluating the joint very deep. Go down, hit auto, and then what we're going to want to do is just crank the gain just a touch. Turn on our TGC, and we're going to crank up a little bit of the far field gain there. And it can help to squeeze a tennis ball, which I don't have with me right now, but just even squeezing something like a tennis ball is what's really going to activate, hey, do we see a gaping in this ligament? Do we see a ganglion cyst really show itself? Those are all things that are really going to help out when doing a dynamic evaluation. We have a superficial ligament and a deep ligament down here that we don't see a lot of detail in, but the superficial ligament is very easy to see, which is this band right here. And that sums up the dorsal wrist exam, at least on a basic level. We didn't go into a comprehensive exam for nerves. We didn't go into a comprehensive exam for the TFCC. There's a lot more on the dorsal wrist on an advanced level that we'll cover in a future webinar. Entrapment neuropathies, things like that, that can be a little bit more complicated. But from a general survey standpoint, this is definitely where to start. As far as memorizing all the names of the compartments, not important unless you suspect actual pathology. But I would encourage you to label at least compartment 1, 2, 3, 4, 5, 6 instead of getting into the weeds of all the names. That'll at least show that you did a general survey of those extensor compartments. You want to also document that you looked at the joint and the cartilage. Thank you. All right. Laura, any questions in the chat portal?
Well, we had a couple pop up, but you answered them as we were going, so those were great. I'm looking to see if anyone has any questions. We're going to open it up now, and I know we're at the hour, but
yeah,
a little bit. If you have any questions,
tend to be very long-winded, so we're definitely here to clarify anything.
I'm thinking there's no questions, but showing the recording on our Design the Scan webinars page, which you can find from our main website, sunset.com, under the Education tab. There's a webinar section there. So feel free to check out the oh, we just put in, oh, it just says, hi, this is great. So there you go, Daniel.
Thank you. Wipe the sweat off my forehead now.
Okay. Well, thank you everyone for joining us today. Thank you, Daniel. Thank you, Jamie, back there. Appreciate all your help with this webinar.
Thanks, everybody. Appreciate your time. If you have any questions, feel free to email us, me directly at daniel.shelton@fujifilm.com or Laura at laura.jacob@fujifilm.com, and we can follow up with your questions after the webinar too.
Yep, that is good. Thank you, everyone.
Thank you. Have a great day. Cool. It worked out. Still goes basic, because at the end I'm like, and that concludes with, basic wrist.